Today we're going to do a lumbar spine examination. This starts first by observing the patient gait. Can you please walk forward and turn around and walk back again? Right. And he has a normal gait. If there was any abnormal gait such as an antalgic gait or a foot drop gait or circumduction gait, we would think about if there was any neuromuscular dysfunction. Can you kindly come forward? On inspection in the sagittal plane, this patient has a normal stance. He's not leaning forward or backward. He's well balanced. If he was leaning forward, we would think if there was possibly spinal stenosis. Right? We're also looking to see whether there's a normal lordosis, kyphosis, lordosis, and he has a normal stance. Looking at him from the back, we're looking at the levels of the shoulders, which are normal, and the levels of the pelvic area, which is normal. Palpating, palpate the spinous processes for any areas of tenderness or any gaps which can occur if there is spondylolisthesis. Palpate as well the sacroiliac joint for tenderness, the greater trochanter if there's any tenderness, and the piriformis muscle. Next to the range of motion, can you please lean forward, not touch your toes, and then leaning forward, we're looking at the spinal rhythm, which is normal, looking to see whether there's any asymmetry, and there's a little asymmetry, so he may have a slight scoliosis, but he has a normal lumbar flexion of about 90 degrees. Can you stand up from the neutral position? I'll ask him to lean backward. And this is a lumbar extension, which is normal, 25 with no pain. Are you having any pains?
No.
If he was having pains, I would think about spinal stenosis, and I also think about facet joint disease as well as sacroiliac disease. Can you turn to your side? Go down. Right. Next, any pains?
No.
Huh? Next side. Right. And he has a normal lateral flexion. Next, we will do rotation, stabilizing the spine. Can you twist to the side, left side, right, next side, right, and there's limited lateral rotation, which is normally expected. He has a normal lateral rotation. And let's ask him to stand up on one foot, one leg, right, and on standing on one leg, we're looking to see whether there's any compensatory pelvic tilting, which would indicate pathology. It could be a trendal Briggs positive. Next leg, please. Right. And he has normal, no pelvic tilting. So he has a normal strength gluteus medius, or stand like just properly. And he has normal L4 strength. And let's ask him to work on his toes. Walking on your toes gives us an idea of the motor function of S1. Can you walk on your heels? Walking on your heels gives us an idea of his motor function of L4. Right. And next to the quadrant test, can you lift one leg, stand on one leg, lean backward, and turn. Any pains there?
No.
And this is to check next leg. Turn. Lean backward, sorry. Turn. Exhale, loading. And that's to check if there is any facet disease. I'll ask him to have a seat. And while the patient is sitting, we're going to check the motor function of the lumbar from L2 to S1. We are going to do some past active resistance testing. Okay, can you please lift your leg? This checks for L2, right? Let knee extension, checks for L3. Raise the feet up to you. Raise the feet up. Dorsiflexion checks for L4. Raise it to you. Dorsiflexion of the grade 2 is L5. Bend, press, mash brakes, test for S1. So he has good motor control and normal strength in the lower legs. I would also check the other leg for motor control and strength. The nerves are distributed, and we will check the dermatomes. We can use cotton as well as we can use the pinprick. I will demonstrate with the cotton. Alright, close your eyes. Do you feel this? Every time you feel that, I will just say yes, okay?
Yes.
So the anterior thigh checks for L2, the dermatome, the inner knee for L3, the medial ankle for L4, the dorsum of the third toe for L5, and the lateral ankle for the lateral heel, for S1, and his dermatomes are intact, so the sensory function of those nerves are intact. Okay, while he's in this position, we can also do the ankle jerk, which checks for L3. The knee jerk, knee jerk for L3, right? And he has a good knee jerk, and also for the ankle jerk, which he has a good ankle jerk. We can also check for the Babinski reflex, right? And he has a normal Babinski. An abnormal Babinski would have been raising of the toe and flaring of the big toe and flaring of the legs, and it signifies an upper motor neuron disease. It has nothing to do with the lumbar spine and the lumbar spinal nerves. Okay? Another test would be the test for clonus, and he has no clonus, which is another sign of myelopathic disease. Okay, I'll ask him to lie down, please lie. And in the supine position, I'll do the straight leg test, which is a test for sciatica, and it's a passive test. He'll raise his leg to the point of where he's having pain. Are you having any pain? No. And he has good leg extension. If he was having pain from about 60 degrees to about 120 degrees, we think that he may have some sciatica, and in order to alleviate that, I would either bend the knees. Bending the knees would alleviate if it was sciatica, and dorsiflexing would aggravate the sciatica. Right? I would also I'll test the other leg. It's called well leg test, and if he did have pain on the side that is injured, if the well leg test also caused pain, it means to say that he probably has a central disc herniation. Sometimes pain in the back and the lower leg can come from the hip and the sacroiliac joint. So, in assessing the sacroiliac joint, we do the Faber's test, where put his leg there, pressing on the anterior superior iliac spine, and also on the knee. It's a provocation test. Are you getting any pains there?
No.
And there is no pain. I'll also do it on the other side. And there's no pain. Hip pathology can also cause pain in the lower legs and back. So we're going to check the range of movement of the hip. Checking for hip flexion, internal rotation, external rotation, and range of movement, right? As well as abduction. No pains. Okay. Right. Then I'll ask him to lie on his tummy. Can you please lie there? And we're going to stretch the femoral nerve, which is L3, L4. We're stretching the femoral nerve by knee flexion and hip extension. Any pains there?
No.
And there is no pain. If there was any femoral nerve pathology, you would have ipsilateral anterior thigh pain. Once again, knee flexion and hip extension. Next, I'll check for the mobility or the laxity of the lumbar spine. And to do this, the fifth metacarpal, which sits on the lumbar spine on the first level, and lies flat, and using some force, check to see whether there is any spine on pressing or unforcing. This here checks the spinal processes. It checks the spinal ligaments to see whether there's any strain. And that marks the end of the lumbar spine examination. Thank you.